Yeah, just my take on things. My answer to number two. Guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Those cognitive distortions decrease until they cease. Let's go. Guided discovery. Identifying,
All right, I think we're recording. Welcome back, everybody, to Peplow's Ghost, another episode. So excited. I'm thrilled for our next guest here, Cheryl Puntil. I hope I'm pronouncing that right.
Puntil.
Puntil, thank you.
Yep.
Thank you. Cheryl Puntil will be joining us and sharing her experiences, and real excited about the summer we've got lined up here on Peplow's Ghost. Kind of to give a little background with Cheryl, she actually approached us about being on the podcast, so I'm super excited about this idea that the podcast is actually reaching people that are interested and want to be on here. So really encourage you, if you're listening to this right now and you like this podcast, like this content, reach out to myself, Dr. Kate Molino, Dr. Sean Convoy, any of the people that are here on the podcast, and really just kind of reach out and say, hey, I want to be on here. And hey, we'll probably allow you to be on here. We're not very picky. We want to kind of have people, we want to generate that interest and really kind of move that needle and keeping psychotherapy within the role here. So my quick introduction with Cheryl Puntil here is that she is or was recently retired, the CNO, the Chief Nursing Officer at Austin Riggs Center, which is a psychodynamic facility in Massachusetts, and has practiced as a PMH CNS. Melissa, I know you're going to ask me what that means. That's a psych mental health certified clinical nurse specialist. She's practiced for 43 years. So congratulations, Cheryl. You must have got your certification when you were 12. Does that sound right?
Yeah.
I was
in 1998. That was a long time ago.
It's a minute, so that's great. She's also certified as a psychodynamic psychotherapist, and again, really excited to kind of get to know her experience in using these forms of psychotherapy. So my privilege of asking the first question is, when did you first get interested in doing psychotherapy? What was your first foray into it, and really maybe what got you hooked?
So I have a certificate in psychodynamic psychotherapy, which was a 2-year program that I did after my master's in clinical nurse specialist at UCLA. And at that time, California, UCLA split the NP. You could go into either the NP or the CNS. So I chose to go to the CNS. I didn't particularly want to prescribe. And so, but I did learn, because I think UCLA was so biologically motivated, the approach was very biologic, that I learned a lot about medications and, that, and I felt like I needed a little more understanding of what drives people, what motivates people, what are their, I believe that the patients or people have, the unconscious are things that, how do we get their unconscious into awareness to be more self-aware so they can make better decisions, et cetera. So I did the 2-year program at the Southern California Psychoanalytic Institute, and I did actually do psychotherapy at that time with four patients that were older. I worked in geriatric psychiatry, and I did that for most of my profession, but I also take the psychodynamic piece into supervision, into leadership, into working with patients in the inpatient setting, working with students, working in organizations, et cetera, because I think it is just, consumes me in a way that it's just the way that I think dynamically. And, so in terms of psychotherapy, I use the patient relationship and the nursing therapeutic relationship as a way to communicate with the patients and to develop a rapport and to help the patient find their way to self-determination. So yeah, that's just, so that's
great. Well, I appreciate that. I mean, I think what really kind of stood out a little bit to me too is the idea that you use this within organizations as well. I think that's if I can say this term, that's a very CNS kind of thing to do. I mean, I think you think not just of the person, but you think of populations, you think of organizations, and how you can apply that. Do you mind sharing maybe an example of that, how you applied psychodynamic approaches to an organization, or can you think of something just off the top of your head?
Well, it was interesting that because, also the community is very important, right? What's going on in the community. And in a residential center, treatment center where people live, where patients live and staff are involved in the therapeutic community, what I find happening unconsciously is that the patients or the staff will reflect. It'll be like parallel process. We'll be in a meeting, and and go through the same kind of issues or discussions about, let's say, threat to the organization or whatever, and then we'll go into the community meeting, and the patients will be speaking about the same thing as well. And it just seems like, wow, we just talked about that, and so it's this dynamic sort of unconscious way of thinking in an organization that one group affects another group, whether we, where it's not so obvious, but until, but we have to look for that. There's threads that affect the community as well as the professional, et cetera. So there's a lot of links there. And I just felt that was fascinating,
That was fascinating. Thank you for sharing that. That was, very insightful. So appreciate that. Kate, I think you got the next question.
Yeah, it also makes me think, Cheryl, about how, I do group supervision with my psych and P students, and often we talk about how you'll have a day in clinic where everyone is bringing up the same stuff, right? There are these sort of invisible threads that are woven that weave us together. So thank you for that.
Yeah, well, I remember one of the analysts that I was supervised by while I was in Los Angeles. He told me, think of the common thread, like in a rug that's weaved. Mm-hmm. Where is that common thread that's being weaved through the whole rug, or the patient, or the staff nurse, or the CEO, or myself, right? What are the common things that are that's the thread that you have to follow?
Yeah.
And that will lead us. I think. Mm-hmm. Can look at that and evaluate it and really try to understand it.
Yeah. And so my question for you is, if you can, we love to ask here on the podcast, people to share stories of maybe the first time you performed psychotherapy, or maybe a session you had with someone where it was kind of like a aha moment happened and it really taught you something. Is there any situation like that comes to mind that you could share with our listeners?
Well, it's not while I was doing psychotherapy. It was while I was, I think, as a nurse and a geriatric psychiatric nurse. You have to really try to be a detective. And we had a patient once that was very young, who had she had come onto the unit, and she was neurologically the nursing staff felt that she was neurologically impaired, meaning that something had happened to her physically or medically. And there was other people who thought that this was all psychiatric and that she was having a break, a schizophrenic break. And it was being a detective. It was interviewing, I think Hildegard Peplow was the one that talked about knowing your patient. You have to know your patient. And it's how you ask questions and who you ask the questions to, because you're not going to get the answers that you want. Well, the answers that you want, or the answers depend on the questions you ask, right? And so I thought that, and I talked, it was a puzzle as to what was happening with this person. And one of the nurses told me, she said, Cheryl, I think she's worse with the medication. And then I kind of put two and two together, and I talked to the family and the history, and we found out that she had a sore throat a sore throat that was never really treated. And we got her a strep titer, and she had the highest level that they had seen. And we found out that she had the pediatric PANDAS, the pediatric autoimmune neurological disorder, and it was so interesting because the team that saw her as an adult, like the neuro team that saw her as the adult, said one thing completely different than the infectious disease team in peds infectious disease, because she was young. She was right on the edge of adult, adolescent, and completely same person, same manifestation of the symptoms, but completely different assessment. And so you need to look at the patient as well as the family and the context of how things happen in the context. And so that was an aha moment for me about how important it is to be thorough, to really know your patient, to listen to everybody, listen to staff, to look at your patient. I don't think the staff now are not staff, but sometimes you're not looking at, when I go to my primary care provider and get my physical, they don't necessarily even listen to my heart. They don't have me undress anymore. And so are you really looking at your patient? That's what I would think. In terms of psychotherapy, there's always therapeutic moments. And every interaction should be a therapeutic one, or with intention. That's how I kind of see it. And, so, yeah. I don't know if that answers your question, but. Yeah.
I think so. I'm seeing some nods. Thank you for sharing. I would love to pivot just a little, although I hear aspects of what might come out in your response to this next question. How do you see nursing being a leader in performing psychotherapy?
Well, nursing is really, for me, people ask me, how come you didn't become a doctor? How come you didn't become a whatever? I think nursing is, for me, the best profession ever, because it's a conglomeration of a lot of different things, of social work, of psychology, of medicine, of physical therapy, of, and it really, what I feel is that the nurse's role is trying to assist the person become less ill, I guess, or move towards wellness, either because as a response to their illness, or as a response to a perceived or thought of their illness, or to the treatment of that illness. And so we see the patients more in terms of spending time with the patients more than any other profession, I think. And so as a nurse, we have a lot of impact. We can have a lot of impact, and we're in charge of the milieu. We are their eyes and ears, the physician's eyes and ears, or the provider's eyes and ears, and can see patients in the context of their behavior. Because in many ways, the patient will act very differently with the therapist. An hour, at Riggs, they get very intensive psychodynamic or psychoanalytic psychotherapy 4 times a week. And then the rest of the time, the patient is in programs or in community meetings or socializing, or they're in their activity programs and just doing activities. Or else they're just kind of hanging out with the nursing staff or with the therapeutic community staff. And that is when we can gain a lot of information about the patient and what they're thinking and what they're experiencing and what they're struggling with. And we can make an impact then as well. Yeah. And I also think that, we meet nursing staff, they meet with patients. Even when I was on an inpatient unit, on our unit, when I first started, we had community meetings, and and everybody attended. Everybody. It wasn't just this one person. You go to one appointment and then you go to another appointment and then you go to another appointment, and no one, and the patient is seen. All the staff are there too. So I remember that, and that was really, really important. That seems to have gotten lost in the inpatient settings, the community meetings. And then we also have teams, where there's continuity. I know for the nurse in the inpatient setting, we did primary nursing when I was at UCLA, and also when I was at Mayo, we did primary nursing, and also at Rush when I was at Rush. And the continuity was so important because you really got to know your patient. And if the patient also kind of knew what the limitations were or what the boundaries were or the frame, was in the relationship too. And we'd have to keep repeating the boundaries of the relationship or the frame of the relationship. So,
Well, the relationship keeps coming out in these examples, and the humanness and multidimensionalness of a person, of the patient, but as on like a human level, it's really coming out.
And the nurses at the human level, the nurse at the human level with our limitations as well. And we try to clarify that with patients. I think the patient has a sense of what a nurse should be. And that needs to be clarified right in the beginning of the relationship when you're in the orientation phase, when you're trying to develop what the patients collaborate with the patient and build on the alliance and what are we doing together, not what am I doing to you. I think as a psychotherapist, one of the biggest roles is trying to understand the person and to articulate. And in many ways, I don't think patients have difficulty, or I'm using the word patients, and I know it's interchanged with clients, but I use the word patients, and they may have a hard time communicating or identifying what they're feeling or what they're thinking or why they're thinking there, or managing or tolerating their feelings. And I think the therapist or the nurse can help them with that, so they can kind of calm down their systems to really try to, I guess, accept or understand or make more choices or be more responsive versus reactive. That I think that's really, really important. And it's a big part of nursing staff being with patients, being with them, not doing for them unless they can't do it for themselves. And then, and also thinking about, is it developmentally, what are we doing in terms of our interventions that are helping the person developmentally or to mature, as Peplau would say. It's a maturing force. We shouldn't, I guess we can impact that in positive ways so the person grows, like maybe their personality or their thoughts could be less rigid, or we could open up, be more curious about what is happening, so the patient can talk about it versus, right, and be open and allow the patient to be who they are and free to explore with a person, with a therapist.
I love it, Cheryl. I mean, this is, I'm always wondering too, because I mean, I'm assuming all the nurses listening are just getting goosebumps like I am, but I'm wondering how other professions kind of hear this message. Because I agree. I think, nurses within healthcare systems, maybe this is, it's one of those things we're a profession that gets undervalued and ignored a lot, but we're the kind of the glue of an organization, right? We make it all happen. And it's one of those things that, we don't get represented well, like on a billing form. People don't kind of, when they're in trouble, ask for a nurse specifically, but then a nurse is always there, right? The nurse is always going to be there because they're just everywhere throughout a hospital system. So maybe that's my question, maybe to kind of lean that towards my next item to maybe think about or hear your perspective on, or do you have any concerns about psych mental health nurses using psychotherapy either now or in the future?
I have concerns. Well, I don't. I hope that they're getting trained. That's one thing that I'm getting a little bit concerned about. Right, that I get concerned that people are not trained in the way or get supervision, because that's so important. That have that space to think and to be self-reflective, and that I hope that still is valued or that we can bring that back into. I mean, nursing staff, they're running from they're short staffed, they're running from one space to the next, and they don't really get they may not get supervision. I hope that they are getting supervision. With the nurse practitioners, I'm not sure, but they're expected to be prescribing. I know that. I'm actually it's interesting that I'm looking for psychotherapy to be more psychotherapy jobs, and I'm not finding. If I'm not a nurse practitioner, forget it. They don't want me, which is really. And I've said to them, I just think you're making a big mistake, because I think that I can provide a lot more, especially in like maybe primary care settings, where you need an adjunct person who understands medical and psych. And I do understand the medications and sort of the actions and side effects and contraindications, et cetera, and indications. I just can't prescribe. And so I'm discounted. So just much like I think maybe the nurse psychotherapist might be undervalued. I also think that if you're prescribing, there's a huge, Dr. Mintz at Riggs, he wrote a book on psychodynamic prescribing, psychopharmacology. And there's so much about the patient's relationship to the medications and what it means and what they think it might do for them or not do for them, or how they're attached to the medication. That really needs to be discussed. And I hope that the nurse practitioners are using that also as a way to develop a relationship and enhance the effects of the medication. Because I think we know, 33% effective rate for medications?
Yeah, yeah, right.
So
guilty as charged, I think we say. Yeah, right. I mean, it's right. Yeah.
So we can't just be prescribing. We have to be doing both. And I hope that gets emphasized in nursing programs and advanced practice psychotherapy programs. And I do hope that there is a piece. I'm not sure, because I haven't. I remember when I was in grad school that I did have an analyst, a nurse analyst, teaching my psychotherapy class. And I think that's when I first got interested in the psychodynamic piece. Her name was Rose Vasta. I remember her specifically. And she said, you have to like your patient. Find one thing that you like about them and connect to them. And connection is so important, right? For healing and for even suicide prevention, how important connection is. So she sort of got me very, very interested in the psychodynamic piece. And there are nurses that are interested in being analysts to the programs. And I hope that the programs are more willing to accept nurses as analysts, because we have a very big perspective. We have the psych perspective, we have the medical perspective, we have family, we see patients with families, we know family dynamics, systems. I mean, I just think, it's the response to the person's illness or the person's, the treatment of that illness that's the nursing role. And we can impact the person so much.
Yeah,
I don't know if I'm answering your questions or just going off on a tangent.
That's what I hope, really. I mean, tangents are good. We're accepting of tangents here. We're not gonna look to prescribe anything for that. But yeah, no, I think what you said too is important, because the undervalued. I think I've shared a story before where I interviewed for a job once and asked about my ability or capacity within this role to do psychotherapy, and the person interviewing me just kind of really strangely and almost kind of chuckled a little bit, like, that's why we got social workers. I mean, so I just knew that right at that point the interview was over and I wasn't going to be coming there. But it is something that you're right. It's not advertised. And it's interesting too, because, and maybe share your perspective on this too, because we did a study, as part of this team where we looked at, what forms of psychotherapy PMHNP programs are utilizing. And I'm sorry to say that psychoanalysis was kind of far down on the list. It was CBT, it was motivational interviewing, those kind of things, those kind of, bread and butter kind of forms of psychotherapy. And so again, thinking about that undervalued approach here, undervalued as a therapist and then undervalued as a analyst and our dynamic approach, do you have a perspective on that and why that undervalued is there, or?
I think coming from a psychodynamic perspective, you have to, it's harder. I shouldn't say that, but there's no really, is there a manual? Is there? You're the tool. You are the tool that has to be refined and self-reflective and responsive to the patient and hold oneself in, ethically, morally, and come from a perspective of really understanding the patient. I think that's where patient-centered is. It's not doing whatever the patient wants you to do. That's not patient-centered. It's really addressing the core problems, the core issues with the patient. And that it takes a lot of work. And it's not trying to get rid of a problem. It's helping the patient understand where that issue's coming from, and the repetitiveness of it, and the compulsive nature of it, and the rigidity of it. And it's working through something over and over and over and over again, and coming to it with a perspective that, okay, we're doing this again. We're doing this again, and it's okay. It's okay. Because the patient needs time, and they need the relationship, and they need the space. And that, I don't think that's what I'm afraid of, is that there's not enough time. There's not enough. The expectation is, I have this problem. I want to get rid of it. And if you can do it for me quickly, that's great. And that's just not the way that psychodynamic therapy works, I don't think, at all. So.
And Cheryl, I think what you're saying is so interesting and important, because it makes me think about how many of us are working within healthcare systems that see working over the same thing over and over again as a failure. They want to see concrete, measurable, billable outcomes for everything that we do. And that's very hard to quantify, what you're describing. And I think so much of the sort of emphasis on CBT and MI and stuff is because it's brief intervention that is, measurable in some way. And so, there's a bit of a mismatch, right, between our very quantitative system and this very qualitative work. And so, on that note, I kind of want to ask you our final question, which is, given that and given everything you say, what do you see as the future of psychotherapy for PMHNPs or advanced practice psychiatric nurses?
Well, first of all, before I answer that question, I think there's a place for when someone is really, really in distress and suicidal, and even for patients that need to have electroconvulsive therapy, which was very effective so they can kind of get into a place where they can do the psychodynamic piece. So that's just one thing that I want to say. There is a place for that. But so what's the future? I think we hopefully can do more educating of those that hold up our purse strings, I guess. That people that were out there doing it, who are doing psychotherapy, can educate and inform, patients and insurance companies, and even get on insurance companies to try to make, even get on some of the regulatory bodies like Joint Commission and Department of Mental Health, and try to involve themselves and integrate these principles to allow us to practice up to our highest authority. I think that's what we need to do. It's just an open door. There's a lot of opportunities So that's one thing. And I think for faculty, for I'm concerned, this is, just from the undergraduate level, because I taught at Hawaii Community College, but also I taught at UCLA and I taught, et cetera. But what I'm seeing is that like med-surg nurses are teaching psych, and that shouldn't, or someone else is teaching, or they're expecting me to teach. I mean, I can teach fundamentals and go to the nursing home because I was in geriatric psychiatry and things like that. But if you want me in labor delivery or ICU, I don't think that's going to work. Or a med-surg nurse teaching psych. And that's accepted because of the limitations of not a lot of us around. The pay isn't that great. I mean, I feel like I'm a dying breed, really, and when you're an educator and really value and passionate about psych mental health nursing, I don't know how many people are and willing to do the clinicals as well. There are not a lot of people that are willing to do that. So in that way, I'm afraid for for the psych mental health nurse. And I also think we need to advocate for psychotherapy as being effective or necessary, also combined with with medication, that the two together work much better than either one separately. Right?
Yeah.
So
And that's what the data says, right? And I appreciate you talking about this upstream issue of, undergraduates. And I know so many college and nursing programs, I know of this too, where they make you do those four core classes, med psych, gero peds, and you have to do two of them. So many students don't even get psych in their undergrad. And then unfortunately they go into grad school, after discovering their passion for it. And so then they don't have that foundational skills too. So I appreciate you bringing that up. That's something, you're right, administratively and getting on those boards. We need to kind of speak up for this sort of thing, because if it don't, it'll just die on the vine, like you're saying. So one thing, and again, this isn't kind of some of our standard questions, but I think this is kind of, I'm going to call this kind of our after dark part of our podcast today.
After Dark with Peplow's Ghost.
Because I wanted you to kind of be able to highlight your organization, Austin Riggs Center. This is an organization, sounds like you devoted several years of your life at least to. And again, thinking about it as far as, not available to everybody. I will say I'm from the University of Iowa. Finding a psychodynamic facility to send some of my patients is very challenging. I pretty much have to send them to Chicago to find some sort of Adlerian type of approach, which is, psychodynamic in nature. But, one of the questions I do have about your facility, if you wouldn't mind kind of just talking about it a little bit, kind of brag on it a bit, but also kind of share, why is it called Austin Riggs? Because I will share kind of a facility that I worked at was called the Robert Young Center. I'm not old enough, but I understand that Robert Young was an actor on a very wildly popular show for a while, and he's a physician. And so it was interesting that he actually came, it was like from California, he came to the middle of the country to get psychiatric care and got better. And so donated a lot of money. And that's how one of our local community mental health centers was developed and named after. Robert Young Center is the name. So it just, if you wouldn't mind, Cheryl, just kind of sharing a little bit about the Austin Riggs Center and how it got named and what you're maybe most proud of it for.
Well, I can do a little bit of that. Austin Fox Riggs was a psychiatrist, American psychiatrist. And apparently he came to the Berkshires, which is the western part of Massachusetts, and landed in Stockbridge and formed the Austin Riggs Center. It was formed, I believe, in 1917, I think it was. And so in 1907, I think. Or no, it was 1917. I'm sorry. So I think in 2017 we had our 100-year anniversary, And what I want to tout more too, though, is, and there is the emphasis on the residential piece or residential treatment centers, which I don't think are valued or even known. A lot of the residential, you think of substance use, the 28-day substance use program, but there are residential treatment centers that are popping up all over. Menninger has one now, McLean has many, and I think that might be a really good place for a nurse practitioner or a psych mental health or DNP to get involved in that and to use a psychodynamic approach there, because you have people there for a long period of time that are really you can develop a relationship with them. The other thing about Austin Riggs, which I think is another issue that is problematic. When I think of Austin Riggs, I think of the open setting. There are no locked doors. They are there, patients are there voluntarily on their own will. Doesn't mean that they don't have crises and things like that. They do. But we work through that with people, and we build on the alliance, the therapeutic alliance and then they're in a very intense relationship with their therapist. So that's sort of like the centrality of it. And then we, as social work, psychologists, et cetera, nursing staff, therapeutic community staff, also work very diligently and intimately with the patient, right? And they're on teams, so there's continuity. But the other thing about this center is that it's an open setting. There is a very robust patient government, so they have community meetings that are led by patients Monday through Friday. They have representatives from facilities, from from gym, from the activities department. And then there's also an activities department that is really quite, I think, beautiful in terms of it's a non-therapeutic space. So they hire artists. We have a person who's the director of Shakespeare and Company they do 2 plays a year. One is a Shakespeare play, you can imagine, and the patients get involved. And there's also a greenhouse, there's ceramics, there's music as well. And we try to get people there's so much competence. And, people have left Riggs and gone and done, artwork and been artists and been actors. And that has been a huge part of the treatment as well. The creative side that someone needs to explore and value and embrace. And so that's really important. And so there's also a very robust therapeutic community staff. So they're hired to be in the community. They work with the patients in terms of the different programs that the patients are in. There's a nursing program that the patients reside at the inn, which has like 40 beds, and they or a group program, which there's groups that the therapists, that the analysts, the therapists run, as well as nursing staff run, as well as the therapy community staff run. And then there's different groups that focus on living in a smaller home, but still on campus, that focus on how do you live in a family? How do you be a civilian, a community member? What kind of community do you want? So there's a lot of freedom in that. And then there's also trying to get more into the community, into the Stockbridge community or to the Berkshire community, maybe going back to school or working and then kind of transitioning out, all still getting the 4 days a week intensive psychodynamic psychotherapy, which is the core, some central piece of the treatment. So, and they also they have a psychopharmacologist or a psychiatrist or a provider, a physician who provides medications, who could be their therapist, or they could be separate. They get maybe an MD and a therapist. So they have a huge team, a very consistent team, and a dedicated team to the person as well. So It just is it works. But the minimum length of stay is 6 weeks, where there's an evaluation period, and at the end of that, there's a case conference. Everybody weighs in, including nurses, about how their work they showcase their work with patients. So, and it's probably one of the last open setting residential. Well, yeah, they used to have Shepherd Pratt, Chestnut Lodge. I don't know if people were knew about them, but Austin Riggs has been around a long time, and I think it's because the approach that we use is very, very helpful for patients. They transform themselves. They get their lives back.
Yeah.
Yeah.
Thank you, Cheryl. Appreciate that perspective. And again, I didn't want to kind of log off before that to find out about those experiences. But thank you for just sharing that and giving us a peek inside the doors a little bit of Austin Riggs. So. But thank you for the listeners. This is the end of our podcast. We're going to come back with another podcast next week. And so super excited to have another guest and continue to get people excited about this topic. So please like, subscribe, put a comment in there, and we'll be back next week. Take care.
They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. They feel it, therefore it's true. Work hard until those thoughts are finally leaving, so you can be you. Guided discovery, identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease. Yeah, guided discovery. Identifying, challenging your beliefs. Reframing your mind, negative thoughts release. Let it go. These cognitive distortions decrease until they cease.